facial aesthetic practice. So the first talk will be by Dr. Rituja Thomas, who is practicing in Delhi. Over to you, Rituja.
Very good morning to everyone. I thank Dr. Sahil for including me in his talk. So what I'll be covering first is the facial aging and basic anatomy. Under these categories, I will also be including some of the danger zones, which would have also been part of Sahil's talk, but I'll try to cover some of the parts of filler in this as well. So the basic features of aging include bone loss, that is the structural change, fat loss, which leads to volume loss, superficial lines and wrinkles, and overall drooping and descent of the face. Now, progressively, the bone keeps remodeling with age, and areas resorb in a very predictable manner. So, in this, you can see that the mandibular angle, it sort of becomes more and more obtuse with age. So, if we know exactly how the angle would have been earlier, even if you don't have any older pictures, you can plan treatment accordingly. Similarly, with respect to the bone resorption around the orbit, which is more important from the point of view of the oculofacial surgeon, it occurs mainly in the inferolateral and superomedial regions. So these are the areas which primarily need augmentation. Now coming to the perioral area, there is with aging, the skin envelope sort of deteriorates faster than the muscle strength. So the orbicularis kind of overwhelms the perioral skin. So this is why you develop these kind of lines around the perioral area. The temporal area, so this picture basically depicts the hollowing in the temporal region with age. This is also an area which is frequently addressed. So this is a overall basic kind of overview of what happens in each decade. But what I'd like to emphasize is number one, that the aging starts around the third decade, contrary to the belief that mid 40s is when you need to get treated. Early 30s is sort of the right time to start treatments, because the lines start to appear on the forehead, fine lines and the crow's feet start emerging around the eyes, and tear troughs become more prominent at this age. This is why we get many patients, especially women around the mid 30s, who are concerned with respect to this. As you go into the 40s, the nasolabial folds start to deepen. This is one of the main concerns of people in the 40s. And by 50s, the jawline is what is affected mostly. So other than the jawline, most of the wrinkles which already have developed, they sort of go from a dynamic to a static stage. And in the 60s, it's mainly the facial descent. So when we evaluate the face, we look at the shape, that is with respect to the cheeks, how high the cheekbones are, how the chin is, how prominent it is, the length of the forehead, the shape of the eyebrow and the height of the eyebrow, the lid height and the inter-eye distance or the intercanthal distance, the shape of the nose, the lips, the length of the lips, the height of the lips, the cupid's bow, the skin clarity and the texture. So these are basically the superficial and the deep fat compartments which are shown here. Now, various ligaments separate these fat compartments, which make them sort of follow a basic area which they stick to. The deep fat compartment is what is important to us as well. That is the retroorbicularis fat, and that is what is usually augmented with fillers. The various muscles of the face, what we need to most importantly keep in mind with respect to for us as oculofacial surgeons is the location of the corrugator, the procerus here, the corrugator here, the frontalis, the orbicularis oculi, especially the temporal portion, and also the inferior in the lower eyelid for the orbicularis roll that a patient may have. How do we classify wrinkles? It's basically the same thing that I mentioned, the static wrinkles and the dynamic wrinkles. So in your 30s is when the dynamic wrinkles start developing, that is with expression, and by the time you're 60, it's mainly the static wrinkles. So these are the areas which are most commonly addressed. So the lines which develop because of the frontalis, procerus and corrugator, the superior sulcus which hollows, that is the superomedial area, and the tear trough which becomes very prominent. The crow's feet as well, the nasolabial fold. Other areas which we don't usually address is the nasal dorsum. So of late, oculofacial plastic surgeons have sort of been going into facial aesthetics as well. So whenever you're doing a non-surgical nose job, that is when you address these areas. So in order to balance the facial profile, addressing the nose and the tip along with the chin is extremely important. Some of the vessels which we need to keep in mind, the superficial temporal vessels, the supraorbital nerve and the supratrochlear nerve, the nerve bundles, the dorsal nasal artery, the angular artery, the infraorbital vessels. So these are the areas which we commonly need to avoid when we are injecting fillers. With respect to the nerves, the most important would be the facial nerve. So any injection of botulinum toxin which goes too close to any of these areas can affect the motor function of the branches of the facial nerve. Something which is often ignored with respect to filler injections especially is the lymphatic and the flow of lymphatic. So if you can see here, the lymphatics flow in this direction. Now when we inject filler in this area below the eyelid, the fillers tend to sort of accumulate here, especially in patients who get fillers multiple times. They get layered fillers and they may even get fillers of different G prime and different brands. So whenever the filler is repeated before the other filler has sort of worn out, it causes a risk of lymphatic stasis. So this has to be kept in mind before injecting fillers multiple times for the same patient. The other thing is the difference in between male and female aging, and also the overall anatomy of the male and the female face. This is also important because facial feminization surgery is a big part of facial aesthetics today, although it is an up and coming field. So what's important to keep in mind is that males have a very prominent brow and females have a less prominent brow with respect to oculofacial surgery. So what do we do when we do facial feminization? That is, we cut down the brow. The brow is sort of drilled down and made much less prominent to look like a female brow. Some of the areas which we need to be careful about. One is the glabella region. So here we have the angular artery vein, the dorsal vein here. So it's important that when we perform injections in this area, the injection should be performed superficially. However, when we are in this area, that is the tear trough region, they should be performed deeper. This temporal area which becomes hollow with age, this is another danger zone because of the temporal artery which is here, which is commonly biopsied in giant cell arteritis, etc. So this area is a big danger zone, and it's better to sort of use a cannula in areas where you are concerned about vasculature being compromised. So we stay deep in this area and avoid intravascular injections along this area as well, the lateral zygomatic arch, and near the infraorbital foramen, that is the tear trough, where we mainly inject our fillers. The younger patients we inject low viscosity fillers, and the older patients we inject high viscosity fillers. We need to be careful when we inject low viscosity fillers, as they tend to migrate more easily. Now, these are the sort of codes, the MDS codes, which are given by Allergan. I have no financial interest, but these are the codes with which we sort of plan treatment. So, Allergan has sort of given out certain combinations of injections for various conditions, and this should be followed well. But more importantly, it also gives you the danger zones. So as you can see here, right next to the infraorbital foramen, you can see this is one of the main danger zones when you're doing the cheek area. So for example, CK denotes the cheek, but CK1 is the zygomatic arch, that is here. CK2 is the zygomatic eminence, that is the cheekbone, and so on and so forth. Now, some of the issues which you can have if you inject in the wrong area. One would be tissue necrosis because of decreased perfusion. So, in this, immediately the patient would have blanching in that area and pain. So, you stop injecting immediately, massage the area, and immediately put in a hyaluronidase. Blindness would probably be the last and final issue, but it's very difficult to cause this condition, especially if you avoid the danger areas. So I hope you got an overview of facial anatomy with respect to aesthetics, and I thank you for listening, and whoever is watching the recorded version, thank you for watching. Thank you.
It's an excellent presentation. Thank you, Dr. Ritviza. After hearing about the anatomy, facial aging, and danger zones of the face, I will start my presentation. I will present on the use of botulinum in aesthetics and beyond. I have no financial disclosures for this presentation. So, brief overview, botulinum is a neurotoxin obtained from Clostridium botulinum, and it is a powerful neuromuscular blocking agent, and affects up to 3 to 6 months. So its basic mechanism of action is type A blocks the SNAP25 protein, and type B blocks synaptobrovin, thereby decreasing the effect of acetylcholine, causing flaccid paralysis. So immediately within 2 to 3 days you will see the effect, but effect peaks at 14 days, and duration lasts for about 3 months. After that, new terminals sprout out and the action restarts. Subcutaneous and intramuscular both have a similar effect, but subcutaneous is considered less painful, and the toxic dose is very high, so you need not worry about giving Botox. So Botox is available in all these forms. Botox is an actually Allergan company's name. What the toxin is actually botulinum toxin type A, and different types of botulinum toxin are Botox, Dysport, Xeomin, Zuvia, and type B is Myoblock. Basically, it comes in a vial of 50 units or 100 units, and it can be reconstituted with a preservative-free saline and used within 4 to 6 hours, or you can keep it in refrigerator at 2 to 8 degrees centigrade and used up to 6 weeks. In clinical practice, basically Botox and Xeomin, it is in the ratio of 1:1, but Dysport, it is a little bit higher. We have to give up to 2.5 to 4 times that of Botox. And these are all the contraindications: amyotrophic lateral sclerosis, myasthenia gravis, pregnancy, breastfeeding, and especially we should look out for patients with unrealistic expectations, and patients who had an allergy with previous botulinum toxin, and medications like gentamicin, tobramycin, clindamycin, quinidine, and NSAIDs have interactions with Botox, decreasing its efficacy. So patient preparation is an important thing which you should take before giving Botox. Informed consent is a must, and you should explain the procedure, and you should take the medication history of bruising, and you should give instructions before coming to your clinic that patient should not have any makeup, and you should explain her about the procedure. And after giving injection, the patient should be in upright position at least for 4 hours. Frequent squeezing of the injected muscles, and laser should be avoided. Preferable laser should be avoided at least after 2 weeks of giving Botox. So these are all the aesthetic indications we give for forehead lines, eyebrow lift, for frown lines, for crow's feet, for bunny lines. I'll describe each one in detail. So again, I am revisiting the anatomy. As you can see, these are the vectoral forces. Frontalis direction of action is away from the tuft. Orbicularis is in a circular manner, and this is the direction of procerus and corrugator superciliary. So for frown lines, these are the 5 points. For procerus this is the center point. Basically, you can give 2.5 or 5 units depending on the severity and depth of the frown line. So if you are a beginner, you can start with a smaller dose and augment it later on after 2 weeks, seeing the effect. The center point is for procerus, and the lateral 2 points is for corrugator supercilii. For male patients with a parallel brows, you can give an additional points in the lateral part for orbital part of orbicularis oculi. These are the points for the forehead lines. You should avoid the lateral forehead, as there is a risk of diffusion of drug into the lower side, causing the drooping of brows. And for brow lift, as you can see in the left side, this is a brow of male, and this is the brow of female. Male brows are little bit flat and positioned at the supraorbital limb, and female brows are little bit curvy in the shape of gull wing. So these are all the 3 points where we can give. So if the patient wants a small lift, you can just give a 1 point or 2 points smaller units and later on augment. These are the points for crow's feet. You should 3 points you should remember is, you should mark the crow's feet whenever the patient is smiling, or you should ask him to make it prominent, and you should only inject when the lines are not prominent. Otherwise, there is risk of diffusion into zygomaticus major, which is just located temporal and inferior to orbicularis oculi. The side effect will be then upper lip drooping, causing defect in the smile. Also, you should look out for patients who have a saggy skin, as there is a risk of drug diffusion into levator labii superioris and anguli oris, causing drooping of mouth. And for jelly rolls, at the pupillary plane, you can give at the pretarsal point 2 international units. Basically, the jelly rolls is because of the hypertrophic orbicularis, causing narrowing of palpebral aperture. For the infraorbital rhytids and for bunny lines, these are the points. For bunny lines, you can give at the points. Basically, it acts on the transversi nasalis. And for infraorbital rhytids, at the junction of pretarsal and orbital part of the preceptal part of the orbicularis, you can give 1 or 2 points depending upon number of folds, 2 units per site. And coming to mid and lower face, basically the anatomy is little bit complex because of the interplay between the contraction of the oral muscles and the rest of the mid face muscles. If there is any imbalance, there can be difficulty in the sphincter action of the oral structures. So for the perioral rhytids, also known as smoker lines and lipstick lines, basically it is because of the hypertrophied orbicularis. These are all the points which you can give. For mild cases, it works well. Up to 1 to 2 units you can give per site. But for moderate or severe cases, you should always augment it with the fillers, and you should always explain the patient about difficulty in whistling, spitting, swishing and kissing. Basically, it is dose dependent, and in asymmetric cases, you should plan carefully. And for lip lengthening, also known as gummy smile, as you can see, if there is more than 3 gingival display, this is known as gummy smile. So for lip lengthening, you can give 1 centimeter lateral to nasal alley, known as Yonsei point. 1 to 2 units is sufficient. If after 2 weeks also you are not getting the result, you can slowly increase it up to 5 units, but don't go right away to 5 units, as there is risk of drooping of corner of mouth because of the injection spreading into zygomaticus major. For labiomental crease, also known as marionette lines, depressor anguli oris is where we inject. It is basically 1 centimeter lateral and inferior to the corner of mouth, and optimal lift is always noted when we combined it with fillers. And for chin softening, we give 2 to 6 units directly into the mental protuberance. Basically, it is because of the hyperactive mentalis. This is a video showing the use of Botox in aesthetics. So we are giving for frown lines, and as you can see, the patient is having more of a bunny lines, and this is for crow feet. Since the patient is a male, we are targeting the lateral part also, as I described earlier. The center one is for procerus. As Dr. Rituja has said, for procerus we give superficially 2.5 or 5. Basically, this patient is having bunny lines also, so we injected up to 5 units. It takes care of the bunny lines and as well as frown lines, and we injected the 2 other points for corrugator supercilii. And for crow's feet, it's always better to go from in to out, and these are the 3 points where we have injected. You have to only make a small bleb, that's enough. And these are the this patient is having very slight forehead lines, so we haven't injected much. We have only given a small dose of Botox. Similarly, for platysma bands also we can give Botox. You can give superficial or intradermal injection into the contraction bands. Dose depends on the number of bands. You can give from 10 to 40 units depending upon the severity. So coming to non-aesthetic ophthalmic indications, we commonly see in our hospital clinics are blepharospasm, myokymia, hemifacial spasm, mix, apraxia of lid opening, eyelid retraction, lacrimal hypersecretion, strabismus, for induction of ptosis in cases of exposure keratopathy, for chronic dry eye, and for lower lid spastic entropion. So I will play a video in which we given Botox for blepharospasm. So first we marked 3 points superiorly and 2 points inferiorly. Basically we are targeting the orbicularis part. You should not go up to level of preseptal part, as there is risk of diffusion into the LPS and there is a risk of ptosis. You should just give a small, raise a small bleb and inject. That's enough. And this is a video for lacrimal Botox. You can use a Desmas retractor, or you can directly ask the patient to look down and elevate the lid. The lacrimal gland will prolapse, and if there is any difficulty, you can use a retractor. So we are giving 2 points of 0.1 ml each. This is mainly for patients with watering. One palpebral part is addressed, and the other point will address the deep part. You should never inject more than 4 units at the first sitting only, as there is risk of drug diffusion into LPS causing ptosis. And this is a video on Botox for lid retraction in thyroid eye disease. You have to. This can be done in office procedure. You have to use a topical paracaine eye drops for numbing. If you are not confident, you can always give a low dose and augment it after 2 weeks. You have to just avert the lid, hold the superior border of tarsus where the Muller's and LPS complex insert. You can give a two site injections, like 2 units at each site. This is a relatively simple procedure, and you can see a gratifying results after 2 weeks. And coming to role of Botox in strabismus, it was first introduced by Dr. Alan Scott. It is effective in the management of small to moderate angle deviations in infantile esotropia. It was given at that time. It is safe and effective in surgically under and overcorrected strabismus. However, there is no conclusive literature showing the randomized studies where Botox is more efficacious than the surgical things. There are only retrospective studies and cohort case reviews. So dosing is little bit different compared to the aesthetic and non-aesthetic parts in the face. For MR we give around MR and LR we give around 3 to 5 units. For superior rectus we give 1.5, and up to 3 years we give 2.5 units in the dominant eye, and a few people give for less than 30 prism diopters 2.5 units in each eye, and few people give for less than 40 prism diopters also 2.5 units in each eye. So it depends on the preferred practice patterns. These are all the indications for which we give Botox for small to moderate angle deviations, basically for less than 40 prism diopters. And if you are combining resection procedures for large angle deviations, you can always augment it with Botox. For acute paralytic cases, to elevate the diplopia, you can give Botox. And for restrictive strabismus like DRS, you can give Botox to show the effect to the patient, how he will be after surgery. And for acquired nystagmus also, you can give Botox. And in active cases of thyroid eye disease where surgery is not done, to relieve the diplopia, you can give Botox. Previously, when the Botox was described, it was done with EMG guided needle, as you see in the diagram. Nowadays, we are giving either as a transconjunctival technique or direct approach. I will show you the videos. So I am giving for MR. You can mark the medial rectus taking a 10 mm from limbus. You have to just hold the conjunctiva with a fixation forceps, and you can introduce the needle directly with a bevel down into the medial rectus belly. And you have to inject. Before injecting, to make sure, you can ask the patient to look towards the direction of muzzle and swiggle left and right. And this is a direct approach where we have exposed the muzzle, and you can give from the middle 1/3 of the muzzle, as the nerve insertion will be in the posterior 1/3. So these are all the complications which we see in the Botox when we give for strabismus. These are all my references. Thank you. And the next presentation will be a video presentation by Dr. Pallavi on the fillers. We'll play that video for you.
is Dr. Pallavi Singh, and I apologize. Good morning, everyone. My name is Dr. Pallavi Singh, and I apologize for not being there in person. But hopefully, at the end of this talk, you'll know a little bit more about my favorite tips and tricks when it comes to injecting hyaluronic acid gel. So, briefly, what we're going to be covering in this talk is some new concepts in orbitofacial aging, some general principles I like to keep in mind when injecting hyaluronic acid, and some area specific tips which I find to be very helpful in my own practice. So one of the things that I think it's important to stress about, and I think Dr. Rizuja already talked about it,
Uh-huh.
but the concept of
ये निकाल
excessive
दो ना.
skin, which was very popular earlier, has changed.
Okay.
That concept has changed to volume loss as we age. So what essentially happens is that the subcutaneous and the deep fat pads that we have in the face, they tend to lose volume, and that gives the appearance of having excessive skin or sagging or drooping is what we see on the surface. So, keeping that in mind, I think the goal of using hyaluronic acid fillers to, for aesthetic treatments, the idea of using these fillers is to basically revolumize the face, replenish that lost volume that we kind of lose with aging. General principles that I like to keep in mind when injecting fillers is, first of all, less is more. So it's very important that you understand that injecting small amounts in the right area may take you a long way rather than injecting large amounts everywhere else. So very important to know where the placement is going to be. And the second thing, which I think is something that we don't really talk about very often, is just observing faces and understanding how lights and shadows play out on the faces. Because if you move the light reflex even by a couple of millimeters, that can really change the way your shape looks. So essentially what we're trying to do when we're injecting hyaluronic acid fillers is change that light reflex just by a bit and making the face look better. So, talking about area specific tips, one of my favorite areas to inject is the brow fat pad. Now, we all know the anatomy of the brow fat pad. It is the roof, which is the retroorbicularis ocular fat. It meets in the lower lid, it meets the SOOF over the lateral orbital rim. And essentially, with aging, you see a deflation of these fat pads. And what we're trying to do when we're injecting filler here is just revolumize these fat pads. And so it's important to know whenever you're injecting the brow fat pad that you always notice the 3D structure of the eyebrow, because the eyebrow is formed by the roof fat. And it's important to not get distracted by the eyebrow hairs, because you can pluck or laminate your eyebrows whatever way you want, but you cannot change the roof fat. So it's very important to look for that nice fullness, or to recreate that nice fullness whenever you're injecting in this area. For instance, if you look at Wahida Rahman when she was younger, she has this nice fullness which kind of has deflated with age. And so oftentimes it happens when patients come with a deflation of this, lateral fat pad. What they come to us saying is that there is excessive skin, and they want a blepharoplasty. So it's important to recognize where there is volume loss, and sometimes just refilling that volume can take care of their aesthetic concerns rather than doing a blepharoplasty. Now, where to inject? You want to inject just below the orbicularis, where essentially the roof fat pad is, and I like to inject inject laterally because there are no major vessels in this area. Obviously, medially you want to be very careful because you have the supratrochlear and the supraorbital, the neurovascular bundle over there. So that's important to consider. But just kind of going laterally and filling right below the, right below the subcutaneous area in the roof fat gives you a really nice result. This lady, she had, these superior orbital hollows filling in the brow fat pad, really gave her a nice fullness. This man came to us after a blepharoplasty. His eyes look hollowed out. It's not a good look. And just, filling the superior sulcus in the brow fat, it makes him look much more normal, much more youthful, so to say. The other area, the second area that I'd like to talk about is the tear trough, very commonly talked about area. The anatomy is something, again, as ophthalmologists, we're aware of that the major vessel that we need to be wary of in this area is the intraorbital artery. And you know how the orbicularis is, and you have the orbital retaining ligament, above which, if there is deflation of the fat pad, that essentially forms what your tear trough deformity is. And you remember the roof and the SOOF pad we were talking about earlier, when they kind of deflate with age, what you get is this orbital rim hollow. So where we would like to inject when we're talking about tear troughs, and now this is important, you want to again inject in the SOOF fat. So it's going to be in the suborbicularis layer and the preseptal layer. I like to use a needle over here rather than a cannula because the skin is very thin in this area. So you'd rather place small aliquots of filler in multiple areas, and rather than injecting a bolus in one area. So small amounts, I think I tend to get more precise results with a needle over here, and that's what I prefer. And so this is just a short video. It just goes to show you that you want to keep your needle almost flat, just below the just below the orbicularis muscle here, and just do small amounts, like really 0.2 or 0.3 cc's of filler. And then once you've injected, you also want to use your finger to kind of flatten it out, because you do tend to get lumps. Filler does tend to get a little lumpy in this area, so it's important to be cognizant of that. Tear trough filler, the good thing is it lasts for a long time. This was a patient I did, and the below photo is a 1.5 year follow-up, and you can see that she's doing really well. I don't think she's going to need another layer for a year. So it lasts for anywhere between 1.5 to 2.5 years, and you just need small amounts in the right places to make a good difference. Again, another area that is one of my favorite areas to inject is the temporal fossa. Now we know what the temporal fossa is. It's essentially this bone which lies behind the lateral orbital rim and above the zygoma over here. And what you have on top of that is the temporalis muscle, the deep and the superficial temporal fascia. And what happens with age is that all of the muscles over here start to get resorbed, and the subcutaneous fat pad also tends to get deflated. So what that creates is a big concavity on the temporal fossa, which is a sign of aging. It does not look good. So when we're trying to rejuvenate this area, what we really want to do is just fill out that concavity. Now, we know that the neurovascular bundle in this region lies between the deep and the superficial temporal fascia. So I think it's what I like to do is just go straight down to the bone. You're piercing through the muscle as well, and if you're injecting over the periosteum, you know that it's pretty safe. Just go straight down perpendicular to the bone over here, and you're not going to sort of encounter any vessel over there. So I think it's a safe area to inject. And what you can really do is just inject a slow injection, and you can inject a bolus of about 0.2 cc's or 0.3 cc's, and you can just see that sort of temporalis muscle bulge out. And you can see the before and after pictures over here from this paper by Val Lambros. You can see how she's got this really big deformity on the left side, makes her look hollowed out, makes her look old. And on the right, after the filling, she looks much more natural. And one of the good things about filling the temporal fossa is that it looks better, but nobody can really tell what has been done, which is essentially, the basis of all aesthetic medicine, that you should look like yourself, but people shouldn't be able to tell what has been done. The fourth area that I'd like to talk about, again, is something which is very commonly talked about, the mid-face filler. I think over here it's just important to understand, number one, the anatomy. We know that the highest point of the face, so to say, is kind of right here in the pre-zygomatic space where the zygoma, takes a turn to the back. And it's important to understand the fat pads over here. You have the deep lateral cheek fat pad, and medial to that you have the medial fat pad, which has a superficial layer and a deep layer. So just understanding the anatomy is important, because we want to revolumize these fat pads. And what happens with age is, as they lose volume, your cheeks tend to sag down, the nasolabial folds become more prominent. So that is the thing that we want to sort of reverse or correct. Now, in terms of where to inject, a lot of people like to sort of draw a line from the lateral ale of the nose to the tragus and draw a line down from the canthus. I think for me, I find it more helpful if you're just, if you just palpate the zygoma over here, right at the bottom, the inferior orbital rim, and you can see the zygoma, and you can almost feel you can really feel the point where the bone, sort of turns backwards, and that is the highest point. So where you can inject over there, you have the transverse facial artery and the zygomatic facial artery again in that area. But if you go right down to the bone, I think it's pretty safe, because the arteries are more superficial. Another trick that I like to use for this area is, like, I like to use the cannula, because you can create multiple tracts, and then you can inject as you're taking the cannula out. So that creates a more uniform kind of lifting effect. And I heard Dr. Debraj Shom describe it very beautifully. The whole idea of injecting in the midface is thinking of a tent, and you're holding a pole to sort of lift up the tent. And so what that does is, when you're injecting in this area, you're lifting all of these tissues up, and that gives support to your nasolabial folds, effaces them, also gives support to your orbital rim. So just an overall good effect on the face. But I think it's also important to understand, whenever you're injecting the cheeks, to not overdo them, and to understand that you have to harmonize it with filling the rest of the face. So you can't just go nuts in one area and start injecting like about 1 cc here and 1 cc here, and not inject in any other part of the face. So just doing small balanced amounts on in the entire face is more important than injecting more in one area. So these are some befores and afters. After mid-face filling, excellent results in these cases. But these were also, good cases to sort of inject filler in. The last area that I'd like to talk about is the piriform fossa. Again, one of my favorite areas to fill, because I feel like it gives you, the biggest bang for your buck, so to say. Now, what is the piriform fossa? It's this fossa over here. It is at the base of the ala of the nose. Medially, you have the levator labii superioris, and laterally, you have the deep medial cheek fat, enclosing this area. And the vascular structure that we need to be sort of, cognizant about in this area is the angular artery, which runs in the roof of the space. So what happens with age is the maxillary bone gets resolved, as you can see here, and the nose kind of tends to go back, leads to elongation of the philtrum, and the lips also tend to sort of evert out. Not a very good look. And if we inject filler in this area and sort of replenish the bony volume, what you do is pushing that whole structure forward, giving a more natural look to the philtrum and the lip. So not only it effaces your nasolabial fold, but it also provides support to the lip, which is something that is not really talked about, and it can reduce the amount of filler you might need for your lips. So that's an important point to keep in mind. Now, where you want to inject, again, in this case, because the angular artery runs in the roof of this space and it's a little superior, I like to inject right here and go right down to the bone, because again, when you're touching the periosteum, the chances that you've hit an artery are really reduced. So I think it's pretty safe to do that. So go right down to the bone. You can inject, sort of slow injection again of a bolus of about 0.1 or 0.2 cc's on each side. And then you can always come out, see how much of a difference it's making, and then go in and inject again. And I think it makes a really good difference. So you can see here this lady, if you look at her lips in the picture titled B, they look much better, but she's had no lip filler done. The only thing they did was provide, support to the to the piriform fossa, giving it that forward projection that looks very nice. This was one of the patients I did when I was at UCLA, and you can see how her nasolabial folds are effaced, and it looks better. So again, I think one of my favorite areas to inject. So to summarize, I think it's important to understand that a lot of your upper and mid-face aging relates to the loss of volume in the subcutaneous and the deep fat pads. Less is more when it comes to filler, and I cannot stress that enough. Very important to understand how lights and shadows work. It's always helpful to sketch or to just observe photos just to see what a good sort of what an ideal face looks like. What the lights and shadow how they play out, because that can help you in deciding where to inject. One short tip for each specific part that I talked about. Eyebrow filling, always think about the three-dimensional shape of the roof fat. Don't get distracted by the hairs. For the teardrop, always do small aliquots in multiple spots rather than doing a bolus injection. For the temporal fossa, it's always safe to inject underneath the muscle so you can go perpendicularly. And always remember that when you're filling the midface and the piriform fossa, you're kind of replenishing the lost bony volume. So keeping that in mind can help you design your injection pattern. I'd like to thank Dr. Gorberg for teaching me everything I know about fillers, and hoping to see you next time in person. Thank you.